All right, today we're tackling a topic that is absolutely critical for anyone in anesthesia: laryngospasm. This is one of those high-stakes, can't-miss airway emergencies that you just have to master.
So here's how we're going to break it all down. We'll start with the fundamentals. What is it and what's the big deal? Then we'll get into the why, the actual pathophysiology behind the spasm. After that, we'll get really practical and talk about who's at risk, how to prevent it, and of course the step-by-step game plan for when it happens, including those really tough advanced scenarios.
Okay, let's jump right in with Section 1, the basics. Before we can even think about managing it, we have to be on the same page about what laryngospasm is and why it matters so much.
So what are we actually talking about? Well, at its core, it's a powerful, sustained, and totally involuntary shutdown of the vocal cords. Now, here's the key thing to get your head around. This isn't some disease. It's actually a primitive reflex, designed to protect us from aspirating. The problem is, under anesthesia, that supposedly protective reflex turns into a full-blown, life-threatening airway emergency.
Now, you might see this number, just under 1%, from the classic Olson and Holland study and think, okay, so it's pretty rare. But honestly, that figure is dangerously misleading. The risk is not spread evenly at all. And this is exactly why that number is so deceptive. Just look at how the risk explodes in certain groups. In kids, the incidence more than doubles. In infants under 3 months, it triples. And then you get to airway surgery, like a tonsillectomy, and the risk just skyrockets to as high as 25%. Think about that. For these patients, laryngospasm isn't some rare event. It's an expected complication you absolutely have to be ready for. And when it does happen, the consequences are severe and they are fast. This data from the Australian Incident Monitoring Study is pretty sobering. I mean, over 60% of cases lead to significant hypoxemia. And from there, it's a very rapid, slippery slope down to bradycardia, pulmonary edema, aspiration. You get the picture. The stakes are incredibly high.
Okay, so on to Section 2. To really get a handle on how to manage this, we need to understand the mechanism behind it. Let's dig into the actual wiring of this reflex.
It's really just a classic reflex arc. Think of it like a tripwire. Some kind of stimulus, could be blood, a secretion, you name it, hits the glottis. That signal travels up the sensory pathway, which is the internal branch of the superior laryngeal nerve. The central nervous system gets this danger signal and immediately fires back a motor response down the recurrent laryngeal nerve. And the result? All those little laryngeal muscles contract and, bam, the vocal cords slam shut.
So, moving on to Section 3. Now that we get the wiring, we can start to anticipate who's most likely to have a problem. This is all about getting ahead of the curve, identifying the risks, and hopefully preventing it in the first place.
Think of this as your pre-flight checklist. The risks really fall into 3 main buckets. You've got your anesthetic factors: being too light, using an irritating agent like desflurane, or just having blood or secretions in the airway. Then there are patient factors. Young age is a big one, as is any kind of airway hyperreactivity from asthma, a recent cold, or even passive smoking. And finally, surgical factors. Airway surgeries like tonsillectomy are at the very top of the list. Now, a really critical decision point is your extubation strategy. You've got 2 main choices: extubate deep or extubate fully awake. And you know what? The evidence doesn't really prove one is superior to the other. But what is absolutely crucial is that you commit to one. You cannot be in between. That twilight zone, where the patient is getting light but doesn't have their protective reflexes back yet, that is the danger zone. And that brings us right to Section 4, because despite our best prevention efforts, it can still happen. So let's walk through the exact action plan for when you're faced with this airway crisis. First, you have to recognize it, and fast. You'll hear that high-pitched inspiratory stridor. You'll see the signs of increased effort, the classic tracheal tug, paradoxical chest movements where the chest goes in and the belly goes out, and on the monitor, the oxygen saturation will start to drop like a stone. But the single most terrifying sign? Silence. A silent chest means complete obstruction. No air is moving at all. Okay, here's the drill. It has to be automatic. First, call for help and remove any stimulus that might be causing it. Then, get that airway open with a firm jaw thrust and apply 100% oxygen with continuous positive airway pressure, or CPAP, to try and stent it open. If that doesn't work, deepen the anesthesia with a small dose of propofol. But if you're still obstructed and the sats are falling, you have to escalate. That means paralyzing the vocal cords with succinylcholine. So, let's get into our final section, advanced management. The standard plan works well when everything goes to plan. But what about when it doesn't? Let's tackle the most challenging scenario. What do you do when you don't have IV access?
This is the question you have to have an answer for before it happens. It's a real possibility, especially during a gas induction in a child. You're in a crisis, the clock is ticking, and your main rescue drug needs a line that you just don't have. You need a backup plan.
And this is where knowing your options is absolutely vital. You can give succinylcholine intramuscularly. It works. The dose is 4 milligrams per kilo, and it'll take about a minute to kick in. You could also try the intralingual route. But in a true can't ventilate, can't oxygenate situation, your fastest, most reliable bet is the intraosseous route. The IO gives you an onset that's almost as fast as an IV.
Now, you've probably heard about other techniques, right? Things like Larson's maneuver, where you apply firm pressure behind the earlobe, or gentle chest compressions. And look, there are plenty of anecdotal reports saying they work, but we have to be cautious here because the hard evidence is pretty limited. These should only be considered as adjuncts, and they must never replace or delay the core algorithm we've already gone through. So let's end on this critical takeaway. In laryngospasm, everything comes down to time. Your ability to immediately recognize what's happening and execute a clear, rehearsed plan is the only thing that separates a minor blip from a catastrophic outcome.
And for anyone who wants to dive deeper, this whole explainer was based on a fantastic review article from 2014 by Gavel and Walker called Laryngospasm in Anesthesia. It's a really foundational piece of writing on this topic, and it is well worth your time to read.